So, good afternoon for all. Thank you for the invitation to participate in this webinar promoted by the International Society of Unilateral Biportal Endoscopy, this Mexico station. And I congratulate the entire organizing committee for such a brilliant achievement. In this presentation, I will explore some aspects of the advances in the UB technique and in its current stage of development. I highly recommend reading this article, which gives a good overview of studies related to biportal spinal endoscopy, making an interesting analysis of the geographic distribution of publications, the most covered topics, where the main publications are concentrated, which articles are most cited between peers, in addition to other important information. Despite this, even though it's a recent published article, it is a somewhat outdated work due to being limited by compiling publications until 2021. Note that in this publication, 98 studies were found, of which only 74 were selected for more detailed analysis. Also note the rapid increase in publications, especially since 2018, that is just almost 6 years ago. I did my own research and really noticed the rapid evolution of publications on biportal spinal endoscopy. It's interesting to note that only in 2022, there were more publications than throughout the previous time, and the number of publications was surpassed in 2023, surpassing for the first time the number of 100 publications in a single year. It's necessary to emphasize that the majority of publications refer to the treatment of degenerative pathologies of the lumbar spine. That is, pathologies are usually treated since the origins of the UB technique and still today, the main target of treatment. When restricting the search for articles on PubMed specifically involving the cervical spine, there is a scarcity of articles concentrated between 2017 and 2023. And in the last 2 years, the average was 6 publications per year. That is, 1 every 2 months in a median. At first, it seems like little to me, but we are talking about a very recent technique, isn't it? With its principles well defined, but with its application still in a phase of careful and sensible maturation. The same happens when limit the research to approaches to the thoracic spine, where publications from the last 2 years were the first one, and with a frequency of 1 every 4 months. The youth of the UB technique is reflected in the analysis of the main articles cited in the literature in the various existing publications. The vast majority among the 10 articles with the highest citation are technical notes. Some are from prospective studies carried out in a single center involving case series, and only one that was considered to have been carried out in a randomized and controlled manner. And this specific article was not about UB, but about full endoscopic monoportal surgery. In that article I mentioned on the first slide, these are the search keywords most related to UB. This is the current universe of interest that the technique has aroused among those searching at PubMed over the last few years. It's notable the increase in research interest in the subject in recent years and how this interest has been related to degenerative diseases of the lumbar spine and their results when compared to other techniques. Therefore, I would like to make some modest initial conclusions, serving as starting points for the study of the potential involving the UB technique, as well as highlighting points of evolution of the technique that have already become reality today. Well, firstly, when you talk about UB, whether for the treatment of lumbar or cervical pathologies, we think about posterior approaches. Would this be a conceptual limitation of UB, or could this technique also be applied to other accesses? Likewise, when talking about UB, at least in the literature data and in the main search terms on PubMed, the vast majority of cases are degenerative diseases. Would UB technique be limited to resolving these cases, or would there be the possibility of its application to other pathologies? Continuing, in principle, all the pathologies treated in all the publications that I could access talk about extradural pathologies. Would the dura matter and its content be a limitation for the UB technique? Would pathologies with potential for dissemination, such as infection or neoplasms, also be a limitation to the use of this technique? The limit of UB would be limited to pathologies of the subaxial spine. These are questions that I want to debate, present a point of view, and discuss these limits if they actually exist. Even if we recognize that these limits exist and that the current state of the art of UB is the effective, sustainable, and cost-effective treatment of degenerative pathologies, especially of the lumbar spine, whose techniques we are developing and performing, and forming the basis for progressive development of this philosophy of surgery. We have to think and recognize that we are facing a new technique. Everything that seems like a limit today will soon be routine and the base for new leaps forward. At the moment, we know the ocean of potential of this technique just enough to wet our feet on the beach. Of course, some of us have already put their boats in the water and started to explore a little more and move away from the shore. But the certainty is that much is still to come. Let's start by talking about possible access routes other than posterior access. In this article, for example, all very recent, this one is from 2023, the author defends a reinterpretation of the aspects involving anterior endoscopic access to the lumbar spine for interbody fusion. In the past, many complications have occurred with this access route, but currently, even with new endoscopic equipment, this possibility has not been explored with due care. In fact, this is the author's final conclusion in this article. There are no current studies that focus on the possibility of endoscopic access to the lumbar spine, nor on the possibility of this access being performed biportally or multiportally. These are some works that were included by the authors in this study, the majority published from the USA, a few from Europe, and one just from Korea. The conclusions, as I said, is that laparoscopic ALIF, endoscopic ALIF, do not appear to be supported by published studies, although the articles included do not represent the recent technological advances. So, the purpose of this study was to identify, via literature search, whether any groups have investigated endoscopic ALIF using modern endoscopes. And it appears that no such investigations have been conducted. So, biportal access to anterior lumbar spine is a real possibility that has already to be addressed. This is a case carried out in our clinic in Brasilia, Brazil, using, between quotation marks, a biportal endoscopy to assist in the resection of a recurrent extruded hernia in the lumbar spine. We considered that even with an open access, in this case, the use of the same principles of biportal endoscopy could substantially help to better visualize the hernia, the nerve root, the dural sac, as well as to better control epidural bleeding. And that is what we observed and ended up repeating in other cases. I think, and I agree, that I may not be, this may not be real unilateral biportal endoscopy, but is absolutely the use of the principles of the technique to effectively solve a problem from a patient. As you can see in this image collected from the surgery, It is possible to visualize with good bleeding control the root exiting throughout the foramen, the dural sac, the posterior longitudinal ligament, the vertebral plateaus, and the disc fragments, with perfect differentiation and identification of the tissues, remembering that it was a reoperation. It was possible to perform a precise, safe decompression with minimal tissue trauma. 1 month after surgery, the patient had already resumed sports such as swimming, which he had not been able to practice for a long time. This other case, I'm sorry, but very badly documented, is other case, almost a pilot case from a video-assisted LLIF, a lateral lumbar interbody fusion, that he also did at our clinic. It was not a real UB again, but is endoscopy using 2 hands as in UB and with the same instruments. So it was at least difficult not to remember and feel inspired by UB when we thought and we did these surgeries. But for sure, we are not alone. Searching the literature, we can find other case reports that are even more UB than ours. Use it to approach and fusion, for example, thoracic spine. Look at this picture. It is not ours from our clinic, but how can you say that this is not UB, isn't it? Therefore, I think that, in fact, we cannot say that UB is a technique necessarily restricted to posterior approaches. As I said at the beginning of the presentation, this is a point of view that I came to defend and debate with esteemed colleagues present here. This other publication here demonstrates the possibility of using endoscopic resources, not so similar to the traditional UB technique, but with the use, again, of 2 hands, 2 portals, and for the use of optics and the other for the same instruments, as in UB for the treatment of pathologies, different from degenerative diseases. In this article, the objective was to demonstrate the possibility of treating idiopathic juvenile scoliosis using exclusive endoscopic resources. And endoscopically, dissect the blood vessels, perform discectomy, place screws, bars, and apply compression to correct the deformity. See the result of the scars from the incisions. We can say that philosophically, it's not a classical UB, but it is, again, an endoscopic surgery using 2 hands and instruments and principles common to UB. This article, however, is fantastic in my opinion and gives a totally UB recipe for performing thoracic spinal cord decompression in a pathology located anterior to the spinal cord. This is a pathology of the thoracic spine, a calcified disc herniation producing spinal cord compression, and the article describes an elegant and minimally invasive way using the principles of the UB technique to perform a safe and minimally invasive decompression using 4 entry portals. The first 2 portals, more medial, are used to perform laminectomy and costotransversectomy to open access for the compression. The 2 other portals, more lateral, then serve as access to the anterior portion of the canal, allowing skelectonization and subsequent resection of the hernia. Therefore, I consider that the UB technique is not only limited by the type of access, but can also be used in several other spinal pathologies. But how about pathologies located intradurally? Can we one day use UB for the treatment of those cases? Is the dural sac a limit or not? Again, there are already articles proposing the creation of new instruments for the protection and management of the dura mater, including for suturing in case of opening. These are other aspects relating to the management of the spinal cord, roots, and hydraulic pressure, and their consequences for the intradural space, but even spinal or intracranial. Study and prudence need to be used in these aspects. Despite our knowledge of the risks involved in intradural procedures, we are involved in cadaver labs such as this one held at the end of the last year, where we began dural suture training using an instrument to help tighten the knot. Gradually, I believe that intradural pathologies may no longer be an obstacle to the advances of UB. Nowadays, however, there are no studies, even case publications, that allow us to say that this is already a reality. On the contrary, in this brilliant publication, which summarized the next expected advances in spinal endoscopy, the approach of intradural tumors is listed as not being possible advancement of endoscopic techniques. Therefore, we cannot today consider that intradural pathologies are not a limit for UB. I would like one of my esteemed colleagues to refute this statement. Furthermore, I personally believe that it is not a limit, but rather a taboo, which will be overcome over time with prudent and patient studies. But what about extradural neoplastic pathologies? In this publication, again recent from last year, and again a series of cases and a technical note that, as we know, does not have sufficient strength of scientific evidence to recommend it as a standard of treatment. But at least it serves to inspire us and think the limits of the technique that we are studying and teaching. Proposes the use of the endoscopic technique for the treatment of metastases in critical patients with the aim of separation surgery to allow radiotherapy with greater safety. This article describes some cases, this one included here, showing spinal decompression and subsequent radiotherapy programming. The technique was indicated in very critical cases in which open, more invasive surgery would have been contraindicated. In the images of the exams in this publication, we can see that the compression objective was achieved and that radiotherapy programming could be done. But we most emphasize the risk of dissemination of tumor cells during resection and the use of continuous irrigation. There are currently no publications in the literature on this topic, but common sense tells us that this risk may not be acceptable in the vast majority of cases. Thus, for the management of malignant lesions, the endoscopic techniques would be reserved for selected cases as an alternative in critically ill patients in advanced stages of the disease, where palliative support and relief and improvement in quality of life can be offered. But for the management of benign tumor pathologies, less related to the risk of dissemination, we can be more hopeful about the real applications of the UB technique, as shown in this article from 2022. With the effective treatment of this aneurysmal cyst with excellent results. Likewise, the treatment of infectious pathologies carries a risk of dissemination too, but in specific cases, especially in the treatment of bacterial ascites, the role of endoscopy has been better defined, and the concomitant interbody fusion with the UB technique is a reality that has gradually been confirmed by recent publications. In our experience, I have a case of treatment of persistent gram-negative ascites that we are able to efficiently treat using the UB technique associated with interbody fusion with bioactive glass graft and fixation with percutaneous screws. Publications on the treatment of pathologies, the most varied, have been flourishing in the two last years, confirming the progression of the technique. Therefore, despite adequate indications for the treatment of benign and malignant tumors and infections, all care needs to be taken to avoid dissemination of the pathology as it is a technique using continuous irrigation under pressure and limited to fragment tissue resection. Finally, and reaching the final border of the spine, that is the craniocervical transition, we have a few publications on the treatment of fractures and atlantoaxial instability using endoscopic resources, not entirely UB, but which also provide inspiration for future applications of the technique. Without a doubt, the article shows good results, but care and technique are necessary to avoid serious esophageal and vascular injuries. These described techniques, by the way, is monoportal. This latest publication is about almost UB technique for C1, C2 transarticular fixation with bilateral transmuscular access. The upper working channel would be for visualization and dissection, and the lower channel would be for screw insertion. It's a different but inspiring philosophy to be used as a real UB. Thus, the management of craniocervical transition pathology does not seem to be limited by the technique, but by the scarcity of publications on the subject. So, these are my final messages. UB is a newborn technique. Its pioneers describes their philosophy and the foundations of the technique. This technique has matured and consolidated itself as an efficient, sustainable, and cost-effective way to treat degenerative pathologies, especially of the lumbar spine. In the last 2 years, there has been an explosion in interest in the technique and a myriad of new techniques and groups of pathology that have been treated through the UB route. Today, we find ourselves at the stage where, on one hand, we continue to develop the technique, but on the other, we must be carefully observe the limits of each of the possibilities, especially with regards to intradural diseases or those that are tumor or infectious. As a spine surgeon interested in endoscopic techniques and in particular UB, I would like one day someone to ask me, what are you making here operating on this case using biportal endoscopy? To this question, my answer would be, I'm here making history. Thanks.
Thank you so much, Dr. Regis Tavares, for your terrific presentation. The next speaker will talk about comprehensive step-by-step decompression of the ipsilateral recessed by biportal endoscopy. Our guest is Javier Augusto Santander Espinosa from Spain. He will present virtually.